Next case is presented by Emily Eaton from the University of Michigan Kellogg Eye Center. Grand rounds on steroids.
So, Nicholas, did you announce today that these cases would be insoluble?
Good morning. I'm Emily Eaton. I'll be presenting grand rounds on steroids. I have no financial interest to disclose, and consent for use of photography was obtained from the patient. Our patient's a 59-year-old male who has a known history of Graves' disease and received radioactive iodine treatment several decades ago. He presented to an outside ophthalmologist complaining of 5 months of vertical diplopia. His visual acuities at that time were 20/40 and 20/60. He had a normal pupillary exam and demonstrated bilateral supraduction and abduction deficits, as well as bilateral proptosis. His visual field showed early compressive optic neuropathy bilaterally, and his ophthalmologist felt like he had signs of thyroid eye disease with optic neuropathy. Over a course of approximately 4 months, he was treated with IV methylprednisolone, orbital radiation, and high doses of oral prednisone for 3.5-month period. Despite this, he continued to have worsening of his compressive optic neuropathy and was going to be referred to our oculoplastic surgeons at the Kellogg Eye Center for evaluation. Shortly before presentation, he developed new systemic symptoms of dizziness and urinary retention requiring indwelling catheter use. By the time he arrived to our clinic, he had had a very precipitous decline in his overall health. In addition to urinary retention, he could now no longer walk or stand, had new bilateral hearing loss, and severe fatigue, such that he was falling asleep multiple times during his appointment. We did a complete review of his past medical history, which in addition to Graves' disease was also notable for cardiovascular disease, and at this time, he was still on 80 milligrams of oral prednisone. His examination showed continuing decline in his vision to 20/80 in the right eye and 2200 in the left. He had a normal pupillary exam, normal intraocular pressures, and mild deficits on Ishihara color plates bilaterally. His Hertel exophthalmometry showed bilateral proptosis of 24 and 26, and extraocular motility was severely limited in supraduction bilaterally and infraduction in the left eye, as well as milder deficits on AB and adduction bilaterally. And this is a picture of our patient. He has a classic appearance of someone with thyroid eye disease with bilateral proptosis, upper and lower lid retraction, as well as a large left hypo and exotropia. On slit lamp examination, you could also appreciate exposure keratopathy, nuclear sclerotic cataracts, and conjunctival injection. He had a dilated exam done at this time as well, which was normal.
Did you say he's already had a CNS evaluation, CAT scan or MRI?
He has not. He was seen at an outside emergency room for the urinary retention, and they felt that he did not have any other signs of fecal incontinence or other neurologic concerns. They did a CT only at that time, which was unremarkable.
But you did say that he was unable to walk.
He is now, at this point, unable to walk.
Going back earlier, the diagnosis of compressive optic neuropathy was made, and I guess I would love to know what the thinking was. While you can have bilateral disease that makes no APD, in Graves, that's almost never seen. And so I wonder what was pointing them to it being an optic neuropathy.
So he did have a repeated visual field testing, and he did have outside CT orbit imaging as well, which showed significant enlargement of his muscles and some apicial compression they felt. That was the working diagnosis at the time.
And well, I've got your attention. The cumulative dosing of steroids was?
So he was on 80 milligrams of oral prednisone for 1 month. He was on 60 milligrams of oral prednisone for 1 month, 50 milligrams of oral prednisone for 1 month, and then received the 6 doses of IV methylprednisolone as well.
So we need imaging.
Yes, so next step. So this gentleman was referred to the emergency room for his new neurologic and systemic symptoms, and we consulted our neurology colleagues as well as obtained imaging. His CT maxillofacial imaging showed significant enlargements of the inferior rectus muscles bilaterally, as well as bilateral proptosis and some mild apicial crowding, consistent with thyroid eye disease. He obtained MRI images as well. This is a multiplanar reconstructed imaging that is post-contrast. In addition to showing leptomeningeal enhancement, there was evidence of bilateral 7th and 8th cranial nerve enhancement, as well as left cranial nerve 3 enhancement. Lumbar spinal imaging also showed enhancement of the cauda equina. At this point, he was admitted to the neurology service for further workup. He had extensive infectious workup done at this time, which was negative, as well as a lumbar puncture, which showed elevated leukocytes and protein, even after accounting for the elevated red blood cell count. Various infectious and cytopathologic studies were submitted as well and pending. So what about the eyes? We were following this patient very closely while he was an inpatient, and he had evolving ocular findings. His visual acuity remained poor at 2100 and 2400, but he had new pupillary findings, now with anisocoria, with the right pupil larger than the left, and the anisocoria greater in dark than light, with a left ptosis and anisocoria that reversed with aproclonidine. So he was diagnosed with a new left Horner syndrome. Just 2 days later, his anisocoria reversed, now with the left pupil appearing larger than the right and poorly reactive. He also had worsening of his left ptosis and a relative worsening of his adduction. Our concern was for a new left cranial nerve 3 palsy, matching the MRI findings of enhancement that we had seen earlier in his hospitalization. So at this point, I wanted to ask our colleagues here, what is on your differential for this gentleman who has multiple cranial neuropathies, leptomeningeal enhancement, other systemic neurologic findings? We know that he has a history of long-term steroid use and thyroid eye disease. Any thoughts?
Well, just generally speaking, I found it very unconvincing, even after looking at those CT scans, that he had a compressive graze optic neuropathy. He does clearly have leptomeningeal involvement, and I think that our attention should be turned there. The LP should be repeated, and maybe some biopsy done.
And the LP had been repeated a couple times at this point with similar cytologic findings. Again, all the other LP studies were still pending at this time. Mm-hmm. So there's a little bit more information for this gentleman. So we had also been following him daily with dilated examinations, and approximately 4 days into his hospital stay, he developed new retinal findings of bilateral multifocal intraretinal infiltrates. This is a representative photo. There was no macular involvement at this time and no optic disc edema.
He's not had any heart surgery.
He has had a cabbage.
Whoops.
Why is that significant?
Go back to those pictures. I'm blanking. The second I saw it, it was jumped out. What's the name of the, it's almost pathognomonic, from the heart-lung machine. Am I getting, go ahead. No? Okay, go ahead.
So at this point, we felt like his findings appeared like intraocular lymphoma, and we thought that perhaps this could be CNS lymphoma causing all of his other neurologic symptoms. However, over a period of approximately 2 days, his exam evolved, and he now developed large swaths of intraretinal infiltrate with overlying hemorrhage and mild vitritis. There was still no disc edema or no macular involvement, but now our concern changed to something infectious, and we did bilateral intravitreal tap-in injections.
Is it a mycoplasma infection from the heart-lung machine? You're saying no, but I'm not on the right track.
So there was a brief epidemic of this, and Michigan was involved, I remember.
What's the name of the?
I thought it was a fungus, but I may be wrong. So
His surgery had been many years ago. I don't know what the temporal relationship between these
it was
events
fairly
has been, but
abrupt after the surgery.
yeah, his was over a decade prior.
It was a defect in the heart-lung machine, and I
Yes.
presume that that's gone now. So
I can go more into it.
Atypical mycobacteria. So, Nita, Lee, is these two fundus photos, do they make a diagnosis? Isn't that?
well, I think it's very fast for lymphoma.
Exactly.
Yeah. This is
So
not
that's pushing me to some infection, but what it is, I don't know.
Yeah, I mean, the necrotizing retinitis could be consistent with PVRL, primary vitreoretinal/CNS lymphoma, but those punctate lesions, intraretinal lesions, would be somewhat atypical for PVRL, and the progress within days is unusual too.
Around the same time that our vitreous tap results came back, our CSF studies also finally came back, and both were grossly positive for varicella zoster virus. So finally, we had our diagnosis in this gentleman of disseminated varicella zoster virus with multiple cranial neuropathies, viral neuritis, encephalitis, and myelitis. And interestingly, he did never have the traditional varicella zoster rash, but that is true in about 1/3 of patients who have CNS varicella involvement. Unfortunately for our patient, he continued to have new neurologic symptoms, including facial weakness, upper extremity weakness, consistent with transient ischemic attacks. So imaging was repeated, and he had now developed CNS vasculitis related to his VZV. And this can happen commonly because the virus is the only human virus that will replicate in arteries, and it can travel along the trigeminal ganglion to involve the intra and extracranial vessels. Our patient received appropriate treatment with high-dose IVA cyclovir at dosing appropriate for central nervous system varicella, and then he was put on a prolonged taper. He also received intravitreal foscarnet injections in both eyes and a short course of IV steroids for CNS vasculitis, though we had been working on tapering his steroid dose as quickly as he was able to tolerate prior to this point. He was in the hospital for a total of 1 month and then was seen at a 1-week visit in our retina clinic where he was incredibly somnolent. It was very difficult to check his vision, but he had managed to maintain 2150 in the right eye, but was only light perception in the left. At that time, he had no active viral retinitis and no retinal detachment. Unfortunately, we did not see him again as he succumbed to his disseminated infection. So the conclusions from this case are, whenever you're using systemic steroids, please be judicious and be thoughtful about the total steroid dose that you're using, as it can put our patients at risk for opportunistic infections. And always consider varicella zoster when you see these masquerading symptoms of cranial neuropathies. Certainly with the retinal findings, you have a little bit more definitive diagnosis, but it can be a difficult diagnosis to make early on. And thank you to all those involved in this patient's care.
Perhaps one more heuristic to this is the Horners. There have been many reports of this, and that's from the vasculitis that is spreading down.
And one of the interesting points that I've read is that the vasculitis can actually be the cause of many of the cranial neuropathies as well. They can be an infectious process, but if it affects the blood vessels supplying the nerves, that can cause cranial neuropathies as well.
So the appearance of the zoster retinitis was very atypical. Usually you can diagnose it from the appearance, and this was different.
And to be fair, these were representative photos, but they very closely matched our patient. He was an inpatient. We didn't have the capabilities of getting retinal imaging at the time.
Did an OCT show it was a retinitis and not a choroiditis?
So again, we could not get OCT imaging while he was an inpatient. He was unstable from his neurologic symptoms, so I don't have that data.
Was he, did he have mycoplasma testing? I'm not going to give up on that. Because those patients do die. They can develop the disease 10 years after that original fiasco with the machine. And truthfully, he presents the same way these other patients are presented. So,
But in addition to, you mean? You don't mean instead of?
Yeah, in addition
Okay.
to.
All right, we have to keep moving. Thank you.